Hi, everyone. We're going to get started just so we can keep on time here. So this is workshop 13, Epidemiology in Action, Insights from CF Registries and Beyond. Thank you. This is not the session you're looking for. Please stay, it'll be fun. So this is our presentation disclaimer. These are our disclosures. My name is Stephanie. I'm the director of the CF Registry in Cystic Fibrosis Canada.
Hi, I'm Liz Cromwell. I'm the director of biostatistics at Cystic Fibrosis Foundation here in the U.S.
So these are our learning objectives for today. I'll leave it up here for a second. And then I think we can invite our first speaker.
Great. Well, I'm pleased to introduce Dr. Michael Constan. He's the Austin Ricci Chair in Pediatric Pulmonary Care and Research at Rainbow Babies and Children's Hospital, as well as a professor at Case Western Reserve University in Ohio. He'll be talking about clinical characteristics and outcomes of people with CF with homozygous minimal function genotypes.
Thank you. I'd like to thank the session chairs for selecting this abstract for a presentation in this session. Here's my disclosures and those of my co-authors. And as our title reflected, we're interested in people with CF who have minimal function mutations. And there's about 5,000 people with CF worldwide who carry minimal function mutations on both of their CFTR alleles. Now, these mutations result in either no CFTR protein or CFTR protein that doesn't function properly, and they don't respond to CFTR modulator therapies. And this is based on in vitro studies. And so those that are homozygous for minimal function mutations are not anticipated to derive any clinical benefit from CFTR modulator therapy. So there's clearly an unmet need in these patients, and as development of new approaches for disease-modifying therapies that hopefully they will benefit from. But knowing as much as we can about these different populations of patients is important for future research. Now, we know a fair amount about people with CF who have minimal function, who are heterozygous for minimal function mutations and carry the F508del. And both before and after they've been were approved for use of CFTR modulators. What we thought we did in this project was to use historical data from this group of patients to see if they could inform research on people with CF who are homozygous for minimal function genotypes. But it's not known if these two groups of patients have comparable disease progression. So we conducted an observational longitudinal cohort study using the US CF Foundation patient registry to compare these two groups of patients in terms of their demographic and clinical characteristics, and in terms of two disease progression variables, their rate of change in their percent predicted forced expiratory volume in 1 second, and in their annualized rate of pulmonary exacerbations. The time frame for this study was conducted between, the data was used between 2016 and 2019, June of 2019. That date was selected because it was before the approval of elexacaftor, tezacaftor, and ivacaftor. So an index date was defined as a randomly selected clinical encounter in 2017, where the patients had a valid FEV1 measure. They were then followed up for up to 2.5 years. That's why we had that back dated to 2017. But then we also looked a year before for some other baseline characteristics. Patients contributed data to the end of follow-up. Things that might stop them from contributing data would be if they were censored for several reasons mentioned on the slide there, or if they died, or the date of June 30th was obtained. To be included in the analysis, patients had to been greater than or equal to 6 years of age, and that was because we were relying on pulmonary function data. Patients who had a lung transplant used off-label CFTR modulators, participated in any clinical trial, or became pregnant during that analysis prior to the baseline, they were excluded from being included. For the FEV1 analysis portion of the project, the subset of the patients were included. They had to have at least 3 FEV1 measures over greater than or equal to a 6-month follow-up period. That included their PFT at the index date, and that was done not during a hospitalization for IV antibiotics. For determining the rate of change in FEV1, we used the GLI equations, and we used a mixed model for repeated measures, with the dependent variable being the FEV1 measures from the index date throughout the follow-up period. There were fixed effects for genotype, time, age group, baseline FEV1, and a genotype by time interaction. And we used an unstructured covariance approach with a random intercept and random slope for each of the patients. For pulmonary exacerbation, those were estimated using generalized linear model with a negative binomial distribution. It was the rates of the exacerbations over that time period. To account for any differences in the baseline characteristics, all of the analysis were conducted using both an unweighted and weighted population. The weights were generated based on propensity scores, and for the propensity scoring, we used variables that we knew affected decline of FEV1, things like FEV1, age, sex, and race. Then there were a number of other variables that were considered. We did a stepwise regression to include other covariates. The weights were used then to balance the baseline characteristics between these 2 cohorts. Here are the results for the baseline characteristics. You can see in the MF-MF population, we came up with 669 patients, and in the F-MF population, it was close to 3,500 patients. You can see they were very similar in age, very similar with the BMI. One thing that looked different here was the higher proportion of Black patients in the MF-MF group, and also more Hispanics. So then when you apply the weighting to this group of patients, you can see now that they're very similar with their baseline characteristics, that those differences almost disappear. Here are some more characteristics of the clinical features of these patients. You can see even in the unweighted group analysis that they have very similar FEV1 and very similar rates of pulmonary exacerbations. So FEV1 around 74 to 75% are predicted, and 0.8 for the rate of exacerbations annualized. One of the striking things here when we looked at medication use was the high rate of pancreatic enzyme replacement therapy. This is used in the registry as a surrogate for pancreatic insufficiency. It's not surprising because we've known from other analyses that patients with minimal function mutation have a high degree of pancreatic insufficiency. So weighting obviously was applied to this as well, and you can see that the strong similarities between those that are homozygous for the minimal function mutations and those that were heterozygous with the F508del. Here are the results from the rate of change in FEV1. On the left panel there, you can see that in the unweighted analysis, the MF group declined at 1.75% predicted points per year versus for the FMF group, 1.59% predicted. Then, of course, with the weighted analysis, those slopes came together a little bit more similar, and you can see that the mean difference in the rate of change from the weighted analysis only had a 0.04% predicted difference. I should point out that the mean follow-up for this analysis for the patients was 2 years, and approximately 8 FEV1 measures were used for the slope analysis per patient. The previous analysis I showed you were using GLI equations from 2012. If you apply the race-neutral equations from GLI 2022, you can see that they were also similar when you use those race-corrected measures. Again, with the weighted mean difference and the rate of change being 0.05 percentage points between the two groups. We also looked at subgroups by age, 6 to 11, 12 to 17, and those that were 18 or greater. And you can see that there's fairly similar slopes for within each of these age groups between those homozygous for the minimal function mutations and those that were heterozygote with F508 del. Those differences in the annualized changes are presented at the bottom there, and you can see both for unweighted and weighted that the 95% confidence intervals crossed 0. And so we believe that these are fairly similar. Moving on to pulmonary exacerbation rates, those also were similar between those in the homozygous for minimal function mutations and those that were heterozygous with F508 del. Both in the unweighted and the weighted. In the unweighted, the annualized rate for the MFMF was 0.87, and for the FMF, it was 0.84. You can see on the right with the pulmonary exacerbation incident rate ratios approximately 1, so very similar between the two groups. Here's the within age subgroup analysis for those pulmonary exacerbations. And again, you can see within ages very similar rates across all the ages. So from this analysis, we concluded that the annual rate of change in the FEV1 and the rate of pulmonary exacerbations in people with CF who are homozygous for minimal function mutations are similar to those who are heterozygote with the F508 del mutation. And again, it's important to note that analysis was done before that latter group had access to lexicaptor, tezacaptor, and ivacaptor. So these results highlight the unmet need among people with CF with minimal function mutation, the homozygous for minimal function mutation, and a need for disease-modifying treatment for these patients. And I'd like to acknowledge CF Foundation for the use of the patient registry, and to all of the patients and caregivers and clinic coordinators at the CF centers who painstakingly gather this data for submission to the registry, and it's really been an important feature that's allowed us to do these type of analyses. I'm happy to take a few questions. There's a poster session tomorrow, poster number 728. If you want to meet with me and our epidemiologists and others from the study, we'll be happy to address questions there as well. Thank you.
So we should have said this at the beginning, but there's the in the conference app, you can ask questions. If you just find our session, W13, and we'll also take questions from the audience. There's 2 microphones on either side of the hallway.
Well, I'll start off with a question while people are also thinking. I'm really curious, in the 12 to 17 age range, it looks like they seem to have the largest change. Do you think that might be related to puberty or perhaps their higher exacerbation rates?
If it's related to, what was the first part?
The age 12 to 17 seem to have, I think if I recall, the largest rate of change in the study population for FEV1. Oh, you can't
just start.
Oh, you should
Start.
Okay.
Oh, here it is. Sorry, Liz. Let me go back to that slide so I can understand where the audience can see what we're talking about.
Yeah, right there. Yeah.
So your question is that those rates are high compared to the other age groups?
Well, in the 12 to 17-year-olds, do you think with the weighted, that weighted rate of change is higher, something around puberty with growth, or do you think it's their exacerbation frequency, which you showed was also higher?
That's a good question. Because this is from the weighted analysis. I don't have a good explanation for that. But yeah, they are off by 0.5, almost 0.5% predictive. So that's either of those two reasons could be a possibility.
Oops, sorry, we have one question from the app. Do you see the same outcomes for the FMF patients that are treated with ETI as MF/MF patients? And I'm not sure, you don't have any ETI exposed.
There's no ETI exposure in the homozygous minimal functions, right?
Okay.
All we do is have data in, well, obviously the phase 3 trial data contains lots of information on the FMF patients, and that's what it's approved for.
Okay. Great. Any other questions? Okay. Well, thank you so much
Thank
for your
you.
presentation. Excellent. Okay, next up we have Dr. Pravjot Sekhan, who's a fellow at the Division of Pediatric Pulmonology in Columbia University, Irving Medical Center in New York, and she'll be talking on hospitalizations during the first 2 years of life in infants and young children with CF.
Good morning, everyone. Thank you for the introduction and thank you for accepting this abstract. So I'm Prabjot. I'm a second-year pediatric pulmonology fellow, and I'll be talking about hospitalization in infants and young children with cystic fibrosis in first 2 years of life. At the onset, I have no disclosures. So why should you care about hospitalizations in first 2 years of life? Though children with cystic fibrosis are receiving remarkable care, still they are getting hospitalized. High proportion of them are getting hospitalized. We have limited data and limited information on outcomes, etiologies of these hospitalizations. Most of these data are retrospective, limited to registries and claims data, which really cater to a small population. And then we come to this black box of neonatal hospitalization, where we have like little to no data on neonates with CF getting hospitalized. And then we do envisage that these hospitalizations are potentially due to preventable reasons like RSV and influenza. So understanding that, we come to the aims of this study. And the aim of this study was to identify, there are 3 aims of this study. Starting with the aim 1, we want to identify proportion of children who are getting hospitalized in the first 2 years of life. The second is, what do these hospitalizations look like? To characterize these hospitalizations by etiology and determine morbidity associated with each hospitalization type. And third is to, which is the group that is getting hospitalized? And to examine the demographic, clinical, and environmental factors associated with first respiratory hospitalization. So based on these aims, we used data from 2 sources. The first, CF Patient Registry. As we are all aware, this registry was established in 1960, covers around 85% of children with cystic fibrosis. It's a model for rare disease registries with extensive longitudinal data on outcomes of children with cystic fibrosis. But the details of hospitalizations are often missed in this registry. And also, it's not an EMR-based data, it's manually entered, so prone to missing values. The second the data source is Pediatric Health Information System. I'll be calling FIS onwards. FIS is Administrative Claims Database from 49 children's hospitals across United States, which captures data on all the hospitalization encounter, which may be starting from inpatient, outpatient, and other encounters. though it has great detail of hospitalization data, the risk of using CF from ICD codes runs into a huge risk of misclassification of CF, as has been seen with previous registries with this data. So, fortunately for us, these two were merged in 2019. Now, for this study, we use a decade-long data from 2010 to 2020 of children below 2 years in cystic fibrosis patient registry. This is the larger sample size. We had 8,442 children with CF below 2 years. Among these, we had 2,206 children who had a Phys ID. That ID could have been within first 2 years of life, or they could have got it at any point in the life. So, coming to aim 1, we wanted to identify the proportion of children with CF who were hospitalized in first 2 years of life. For this, we wanted the largest sample size as the denominator. We're looking at unique children hospitalized, and the hospitalizations were identified both in CF patient registry and Phys. We classified into two groups, 29 days to 2 years of life and first 28 days of life. I'm going it in a reverse order because that's how we present our data. So, when we look at hospitalizations in 29 days to 2 years of life, 21% of children with CF are getting hospitalized. Majority of these hospitalizations are both in CF registry and Phys, and additional contributions of 16% from Phys and 10% from the CF registry. When we come to neonates, 7% of neonates with cystic fibrosis are getting hospitalized. Majority of these hospitalizations are in Phys. So the point is, both registries are not complete by themselves. They need together to be more comprehensive. Especially CF patient registry has a lot of missing data on neonatal hospitalizations. Coming to aim 2. How do these hospitalizations look like? We wanted to characterize hospitalization by etiology and determine morbidity associated with each type. So the hospitalization data is available only in Phys. So we have to use this combined linked population of CF and Phys. And we are looking at the outcomes based on the primary ICD codes at discharge into respiratory, GI, and other outcomes. And then we are also looking at the neonatal hospitalizations. Now, when we just look at that small green circle, quite a few number of children in that are hospitalized, which is around 76%. And more than half had more than one hospitalization. As you can see in this slide, the etiologies of hospitalization, respiratory comes to be the topmost etiology with around 54.8% of total hospitalizations. When we compare them in terms of age, ICU, hospital utilization data, there is no significant difference between respiratory, GI, or other hospitalizations. In respiratory, we were particularly interested in RSV and influenza, and that's what we looked at. We found out that RSV hospitalization accounted for 10% of respiratory hospitalization in first 2 years of life. We had really a few number with influenza-related hospitalizations. There was again no meaningful difference between the ICU stay or length of stay in these children. Coming to neonatal hospitalization, when we look at the really small green box of neonatal, 26% out of those neonates are getting hospitalized. The length of stay for neonatal hospitalization was long, almost averaging at 3 weeks. And the most of these admissions were related to meconium ileus. Now coming to third aim, the risk factors. We wanted to examine the association of demographic, clinical, and environmental risk factor with the first respiratory hospitalization. So the hospitalization data is in Phys. The risk factor data is in CF patient registry. We are using the combined population where we get the risk factor data from CF patient registry and hospitalization data from FIS. And we did a case control model study. I'll be talking about that in coming slides. First, talking about the risk factors that we looked at. We looked at both time varying and time invariant risk factors. Now, when we talk about time varying risk factors, we made a point to analyze risk factors for hospitalization prior to the hospitalization. For example, if a child is getting hospitalized at 6 months of age, we would look at the Pseudomonas culture prior to that admission, not a Pseudomonas culture at 18 months of age, to make the relations and the data more meaningful. We looked at potentially preventable things like synergies and flu vaccination, and also nutrition. Now, coming to the case control model. So when you start talking about time varying risk factor, I talked about a child who's getting hospitalized. So you have looked at the last 6 months for this 6-month-old child. What about a child who's not hospitalized, who will be functioning as a control? So we took children with aged matched encounters within plus minus 60 days of the similar hospitalization. So as previously mentioned, 1,100 something kids were hospitalized with respiratory in first 2 years of life. We had 1,040 as potential controls, out of which 871 had age-matched encounters. And that was further, a control could serve at could supply multiple age-matched encounters. So we had 2,332 age-matched encounters, giving us 1:2 case control model. And we did a logistic regression model of respiratory hospitalization versus no respiratory hospitalization. And the results are, when we analyzed for risk factor, what stood out was that having a good weight for length reduced the odds of first respiratory hospitalization, while presence of certain bacterial pathogens, especially MRSA, Pseudomonas, and H flu increased the odds of first respiratory hospitalization. The odds ratio for Pseudomonas was almost 2 times the risk factor of hospitalization. We were unable to demonstrate any protective effect of Synagis or flu shot. Our study is not without its own limitation. This is a retrospective study which gets information from 2 different registries and has the limitation of what retrospective studies have. Now, we have used ICD codes for RSV and flu-related hospitalization, and sensitivity of these codes for talking about those hospitalizations is not well established. CF patient registries had a couple of missing variables at multiple points of times, especially regarding Synagis administration and flu vaccination. And we do think some of these factors have played in the role of us being unable to demonstrate the protective effect of flu shot and Synagis. So, to conclude, 21% of children below 2 years with CF are getting hospitalized. Majority of these hospitalizations are respiratory hospitalization, and out of that, 10% are related to RSV. 7% of neonates with CF have a hospitalization with a quite long stay period, around 3 weeks, and bulk of it is due to meconium ileus. Having a low weight for length and presence of certain bacterial pathogens, especially MRSA and Pseudomonas, increases the odds for respiratory hospitalization. I would like to thank Dr. Murray, who interested me in presenting her work, which I did today. We are very thankful to partners at CF Foundation and Children's Hospital Association, who have been invaluable in helping with this. We're also thankful to Dr. Kogan and Dr. Simon, whose mentorship has been invaluable during these years. And now I open the floor for questions.
We'll take one from the floor first, over there.
Thank you for looking at this, and a very nice presentation that was very clear. Did you look at how many of the children who were in the 0 to 29 days, kind of the meconium ileus and others, also had an admission after 29 days. So what's the overlap between your cohort 1 and cohort 2?
No, we did not look at the follow-up hospitalization. So the data finished, like for each child to be in the hospitalization, finished at the 28 days of life. We did not follow them up. But yes, that's a very interesting point to look at.
On that side?
Hi, Chris Goss from Seattle. How did you deal with time? Time is like a big bugaboo in these analyses, and you were following them up for quite a long time, and it probably couldn't be a matching variable, could it? Because you didn't have a ton to match, so again, it's sort of your long time period. How did you deal with kids that were hospitalized early in your cohort versus later in the cohort?
So for each child, it was 1:2 aged match encounter. So if a child is hospitalized at 6 months, we would be matching them with a control who comes for a follow-up in CF clinic at that age group.
I guess I should have been calendar time. So which year of the cohort, not age time. So it spanned a long period of time. The cohort, some were being followed in early in your cohort, like 2006, and the others would be 2010. And how did you deal with that? That's always a challenge.
Yes, I'm sorry, I don't have the answer to that one, but that's an interesting.
Okay, thanks. Okay, thanks.
And
Thank you, Dr.
we'll come back to this side of the room.
Hi, Greg Sawicki in Boston. This was a great presentation, and I'm honestly quite surprised at the high rate of hospitalizations that you are seeing in the database. And from our clinical experience, 20% seems like a lot of kids, but I believe the data. But I'm curious about if you look at RSV and influenza as special, codes of interest. Most were not RSV and influenza. So is there anything more in the data that can tell you what respiratory-related reasons were, or is it really just we're coding it as CF and not able to discern, is it another virus? Is it bronchiolitis? Is it pneumonia? Do we have anything else to sort of help us understand what the causes of the hospitalization are?
Thank you for that question. We did analyze the respiratory hospitalization. We did break them down by ICD codes. I have all that in the poster, 746, and that's the code. So a lot of them had the main primary diagnosis code as CF with pulmonary manifestations. And that's a limitation of when we use ICD codes. Then there were CF with pneumonia, metapneumovirus, but they are a really small percentage. Majority, 50% with CF with pulmonary manifestation, CF with pulmonary manifestation unspecified. That actually became a major thing. And so I've put the main one here. But yes, we did look at the ICD codes and how did they break down and did they have anything else.
Thanks. And just one quick question. Did you also look at ED visit rates? Emergency department?
No, this is just the inpatient hospitalization.
All right, we have a question. Sorry, we have a question from the app. They want to say thank you for highlighting this important scarcity of data in the population. I was curious, have you examined or plan to examine if hospitalizations at a young age is associated with time to access to ETI or I guess any modulator when the patients become age eligible?
So this study is from 2010 to 2020. The ETIs were 2019 approved and not for less than 2 years of age. So we really had minimal to no data on that. But yes, that would be something that could be followed up.
Yeah, go ahead.
Hello, Rebecca from Columbia. Very proud to call you a colleague. I just wanted to mention that at the patient registry luncheon yesterday, among the updates to the patient registry data collection in 2026, I believe were the ability to put in dates of administration for the flu and Synagis vaccines. Is that correct? There was some update related to documentation of vaccines that I could see impacting this.
I don't believe we're adding dates of vaccination.
Okay, so it's still going to be just on an annual basis, a checkbox, yes or no?
Yeah, for the time being.
Okay.
But for the Synagis field, I think they're updating it to, I believe it's Befordis, and there's one other new therapy, I believe, that's been.
I see. So there will be some update. Okay, great.
Okay. Any other last question? Well, thank you so much. Great
you.
presentation. Excellent. Well, I'm delighted to invite my co-moderator, Stephanie Cheng. She's the director of the Canadian Cystic Fibrosis Registry at CF Canada, and she'll be talking about the changing nature of Canadian CF mortality in the post-modulator era.
I got to start my own timer. Hi, everyone. So on behalf of my colleagues, I'd like to present some of our work on the changing nature of Canadian CF mortality in the post-CFTR modulator era. I have no disclosures for this presentation. By way of background, CF in Canada has an incidence of about 1 in 3,850 live births. There's over 4,500 individuals living with CF in Canada, about two-thirds of them are adults and a third of them are kids. And they're almost all seen across 40 CF clinics across 23 cities. So just by way of comparison, the US has about 7 to 8 times the number of CF patients as we do in Canada. There's been a pretty dramatic increase in the estimated median age of survival in Canada and around the world in places that have widespread access to highly effective modulator therapy like elexacaftor, tezacaftor, ivacaftor, or ETI. But it's important to note that there are many parts of the world that don't have equitable access or access at all to ETI or other highly effective modulator therapies. So in this figure here is the estimated median age of survival in the blue circles over the last several years, but also on the bottom is the approval timelines of ETI in Canada. So in June of 2021, Health Canada, which is our body that approves drugs, approved ETI for those aged 12 plus with at least one F508 mutation. But it wasn't until over 3 years later where the label was expanded to 152 rare variants in Canada. So that for those of you in the US, those are pretty different timelines than the FDA. So this is a figure, I'm sorry, it's a little small. This is a figure from the 2023 annual data report showing the estimated median age of survival in Canada over several decades. And the rectangle, the orange rectangle on the right-hand side shows approximately the timeline in which ETI was approved. And you can see in all these other countries, this is Germany, this is all figures from their annual data reports. In Germany, ETI was approved by the EMA in 2020. This is the US, where it was approved in 2019. In the UK, also approved in 2020. And in Australia, similar to our timeline in Canada, approved in 2021. You can see here the estimated median age of survival across the world in these places has actually been increasing over the last several decades. But I think we can see a bit of an inflection point in those orange boxes when ETI was approved, certainly in the last year or two in a lot of these figures. But despite these improvements in survival, every year there are still dozens of young people dying with CF. This is again from the 2023 annual data report in Canada. In 2023, we had 34 deaths in the country. The median age of death was 41 years old. So what that means is half the people who died in Canada were in their 20s and 30s, so quite young. And prior to ETI, typically we were seeing about 50 to 60 deaths in the country a year from those with CF. So the numbers have gone down, the number of deaths has decreased. So the objective of the study was to characterize the deceased Canadian CF population in the periods pre and post ETI availability. So we used the Canadian CF Registry and looked at all deaths recorded between 2016 and 2024. Deaths in 2020 were excluded because ETI was starting to become available through a compassionate access program in the country. And so we wanted to make sure we got a pretty clean cohort on either side of that. Cause of death was pulled from the registry as well as clinical measurements and any complications recorded prior to death. Looking at some cohort definitions, starting from the left-hand side, ETI availability time period was defined as pre-ETI period, which were deaths that occurred from 2016 to 2019. The post-ETI period were deaths that occurred in 2021 to 2024. I do want to note this has nothing to do with whether the person themselves was on ETI, was eligible, or had history of ETI. This is simply the calendar time in which they died. We stratified the results by those who died without transplant and those who died post-transplant. And finally, cause of death was categorized into pulmonary reasons or non-pulmonary cause of death. So pulmonary cause of death does include stuff like COVID or SARS-CoV-2, which is particularly applicable in the post-ETI period. And for those who are post-transplant, the pulmonary reasons does include transplant-related deaths like CLAD or rejection. So before I go into the results, I will be presenting results separately for those without transplant than those with transplant. So we're going to start with those who died without transplant. So they'll always be presented in this blue background. So in the pre-ETI period, there were 121 deaths for those among those without transplant. And in the post-ETI period, 68 deaths. So down about 44%. The sex distribution was essentially the same. The age at death was, people were quite a bit older in the post-ETI period, almost 44 years old, the median age at death, compared to 32 and a half. In terms of CFTR variant on the left-hand side, the pre-ETI period, 88% of people had an F508 del, either homozygous or heterozygous. That pretty much mirrors the Canadian population. I think it's about 87%. For the post-ETI period, it was quite a bit less. It was only 72%, so less than 3/4 of people had an F508 del. And you can see here a higher proportion of people had other mutations, so essentially rare variants. So looking at the history of ETI use, you can see here that only 29% of individuals in the post-ETI period that died had any sort of history of ETI use. Just to recall, 72% of people had an F508 del, and they technically would have been eligible for ETI in Canada at that time. Looking at clinical measurements, the FEV1% predicted, this would be the FEV1 closest to the prior to death, was quite a bit higher in the post-ETI period, 42% predicted compared to just under 32% predicted. Nutritional markers in general, people looked a little bit healthier, less people underweight, more people adequate weight in the post-ETI period. Looking at baseline complications, fairly similar proportions of people with CFRD, maybe slightly fewer people with pancreatic insufficiency, although it's a bit of an different distribution of mutations and genotype here, so that might have something to do with it. Very similar rates of anxiety and depression. We did look at other comorbidities and complications, didn't find too many differences. Again, we're not a very populous country, so small numbers. There might be a little bit of a signal in terms of higher proportion of people in the post-ETI period who had Pseudomonas. But again, that's a bit of an older age group, so there could be an age factor there. And also maybe a little bit of a signal of lower proportion of people with Burkholderia cepacia. But again, in the post-ETI period, but again, cepacia in Canada has been decreasing in terms of prevalence, so there might be a little bit of a time confounder there as well. So now moving on to the post-transplant data and results. These will be presented in green. In the pre-ETI period, there are 104 deaths. In the post-ETI period, 87 deaths. So it's still a decrease, but not as dramatically as those without transplant. So that's a 16% decrease. A slight change, if you will, in the sex distribution. The median age at death was essentially the same. CFTR variant, over 90% of those in the pre-ETI period had an F508 del compared to 80% in the post-ETI period. Again, the general Canadian population, it sits around 87% with an F508 del. In terms of history of ETI, essentially there was no history of ETI, which isn't very surprising to us since ETI is not indicated for those post-transplant in the country. Looking at baseline characteristics or baseline clinical measurements, the median FEV1% predicted was significantly higher, nearly 63% predicted among those who died in the post-ETI period compared to 38% predicted. And the nutritional distribution is very similar to what we saw in the group without transplant. Just generally, people in the post-ETI period looked a little bit healthier. Looking at baseline complications, slightly lower proportions of people with CFRD and pancreatic insufficiency, pretty similar rates of anxiety and depression between the two groups. Now I'm going to sort of pivot a little bit and look at cause of death. So this is specifically pulmonary cause of death. And I'll present the no transplant group first. So on the left-hand side in the blue, those are among people with no transplants. So this is the pulmonary cause of death. About 2/3 of individuals in the pre-ETI period died of pulmonary causes. And in the post-ETI period, it was actually only 41%. So the majority of people who died in the post-ETI period actually died of non-pulmonary causes. For those post-transplant, the proportions were pretty similar. 45% in the pre-ETI period died of pulmonary causes compared to 51% in the post-ETI period. Now, talking a little bit more about the non-pulmonary cause of death. Unfortunately, again, small numbers, not many that were reportable. But we did hypothesize, was there maybe one particular type of non-pulmonary cause of death that was kind of flipping the ratios on us. But it did appear it was kind of an increase across the board of just many non-pulmonary causes of death. So these could include GI, renal, liver, cardiovascular related, so essentially other organ systems. We did see a lot of mention of cancer in the post-transplant group that did include PTLD. We saw mentions of accidental deaths, so drownings, motor vehicle accidents. And there was some report of MAID, which is medical assistance in dying, suicide, and also reports of patients who voluntarily or requested to stop their treatments prior to death. So death among Canadians with CF in the post-ETI period has decreased overall by 1/3, down 44% among those without transplant and 16% among those with the transplant. We identified potentially some gaps in care, or at least the gaps in access to ETI. We recognize eligibility does not equate to access. And so, we saw that nearly 3/4 of people had an F5 weight delta that died in that post-ETI period, but only 29% even had a record of initiating therapy. So potentially some gaps in access there. As we just mentioned, there's those who died without transplant in the post-ETI period had a higher proportion of non-pulmonary cause of death. And as we saw at the beginning with all the survival graphs, as individuals with CF continue to live longer and healthier lives, it's important for CF care teams to be aware of this changing nature of CF mortality. So in terms of the limitations, it is a single country study. It's a registry study, so it's essentially everyone in the country, but it is a single country and not a very populous one at that. And this was a descriptive study, but this leads really nicely to some future opportunities. So for one, linkage to administrative data. Healthcare in Canada is delivered provincially, and each province has a set of administrative data that's generally linked that researchers can use. And we have linked the Canadian registry to a number of these administrative data sets, and it's a great way to get stuff like vital statistics and coroner data, which is a great way to get a more fulsome look at mortality. The other opportunity here is for international collaboration and kind of pooled analyses across all these wonderful registries we have around the world. So looking at, for example, global survival, overall survival, subgroup specific survival. So there's some really interesting natural experiments that occur around the world. Countries that have early access to ETI versus later access to ETI, countries that have no access to ETI. And also subgroups in respect to patients. So patients that have, for example, class 1 mutations that would not benefit from something like a CFTR modulator therapy, are we able to calculate kind of survival on these subgroups of people? And finally, post-transplant survival. I know there's been many people who have done some work on this in different countries and looking at post-transplant survival in the last few years and how things maybe are changing or slightly different than what they used to be, sort of this historical post-transplant CF life. So it'd be really interesting and good opportunity for us to look at that internationally as well. So finally, I'd like to acknowledge the involvement of all those living with CF in Canada who consent to be a part of the CF registry and the incredible work at the CF clinics for them to collect and enter this data. I want to thank my colleagues at CF Canada and St. Michael's Hospital, and that's it.
Okay, do we have any questions from the audience? Oh, excellent. Great.
Hi, I'm Amalia Magre here in Seattle. I was just wondering, and maybe you answered it in your future work, but I wondered why you started with conditioning on death instead of risk of death?
Oh, that's a good question. I think sort of what drew us to this first was our question was, are the people who are dying now different than they were before? I think that was sort of the hypothesis, if you will, that we were trying to answer. So that's why we conditioned on death specifically for this work. Yeah.
This is Chris Goss from Seattle. It was a great study. And I would just encourage you to think about doing another analysis with more countries, because I think this cause of death we just don't know much about it, and it clearly is changing. But I had one quick question. Can you tell any, are there regional differences if you chop Canada into big chunks? I mean, you have small populations, but you've got big chunks.
They're big chunks of land, but very small chunks of people. We didn't look at this regionally. In 1 year we have 34 deaths, so it was we didn't look at it regionally, but it's certainly something to look at. We do see regional differences in a lot of other health-related outcomes, so I wouldn't be surprised if there might be a signal. We can probably pull a couple years of data together, but we unfortunately didn't look at it for this.
Hi, thank you very much for the presentation. Jordan Rodriguez from Seattle, here from Seattle. My question is, I wonder why you decided to divide the time frame in only two big time periods instead of showing the trend by year. I think we're losing some.
That's a great question. I think sort of similar answers to the first question. What we were really interested in was kind of this post ETI, just the description of people who died post ETI. I think we just wanted kind of equal time periods before and after. Just as a point of context, in Canada, the other modulators, so Lumaiva and Tezaiva, they weren't very fully used in Canada, so we didn't have as much concern in terms of trying to capture the difference from those modulators. There were people on ivacaftor, but our main sort of interest was looking at this pre-post ETI period.
Great. Well, I actually have a question for you. So we're seeing a similar trend in the U.S. registry with the cause of death that's being reported is increasingly less, exclusively respiratory related. Mm-hmm. Do you have an opportunity to link to vital statistics data? Can you talk a little bit more about your cause of death data infrastructure in Canada?
Yeah, so, the cause of death in the registry is captured, as checkboxes. And there's a free text field, which is where I got a lot of I sort of parsed out the free text field for some of this work. But yeah, in vital statistics, I can speak more specifically to Ontario, which is the province I'm from, and the data I've worked with in terms of administrative data. The vital stats in terms of, date of death is very up to date and very complete for that. What's a little bit, I wouldn't say it's not complete, but it's certainly delayed is the coroner data set. So that is where you get the cause of death, the primary cause of death, secondary cause of death. That data does tend to be years delayed beyond death. So it is challenging to work with in, I guess, a timely manner. But we do have the registry data linked in Ontario. So it's certainly something we can look at because we do have it linked and we have projects going on.
Great. Well, any other questions? All right. Well, thank you, Stephanie.
Thank you.
I would like to invite our next speaker, Ze Chen, who's a PhD student in biostatistics at the University of Washington. We'll be talking about long-term causal effects of ivacaftor on airway microbiology and lung function outcomes in people with CF. This is an emulation of target trials with the U.S. patient registry.
Thank you for the introduction. Can people in the back hear me all right? Okay, cool. So I'm Ze Chen. Today I'm going to present long-term effects of ivacaftor on airway microbiology and clinical outcomes in people with cystic fibrosis and target trial emulation using US CFFPR.
Can you speak into the microphone?
It's now better? Okay, perfect. There's no relevant disclosure. And here's the outline of today's presentation. So ivacaftor has been shown improvement on clinical outcomes in the RCTs. Registry-based and other observational studies showed real-world benefits, but that are generally smaller in the trial than the trial estimates. However, for the microbiological story, in particular, the effect of ivacaftor on microbiological outcomes remain associational and short-term. So we address this gap by evaluating the long-term effect of ivacaftor on airway microbiology by using a target trial emulation framework in the US CFFPR. So target trial emulation is a framework that treats the observational study as a design experiment. It pre-specifies eligibility criteria, treatment strategies, and assignment, follow-up, outcomes, contrast of interest, baseline covariates, and statistical analysis. It is preferable comparing to the ad hoc adjustment-only analysis as it prevents immortal time and time lag biases and avoids conditioning on post-baseline information. So the typical procedure consists of 2 steps. First is we specify the protocol of a hypothetical target trial that can be used to achieve the goal of the study. And second is we specify how to emulate this target trial using observational data. This is where we operationalize everything, where the key part is approximate the randomization so that our contrast would be interpretable as causal under standard assumptions. So step 1, we specified the target trial. So people with CF at least 6 years old have at least 1 registry record in 2011 and had not undergone a lung transplant by 2011 would be considered as eligible. Then they would be randomly assigned into either the treatment or the control group, with the treated group initiating ivacaftor in 2012. And they would be followed for data collection until censoring or the end of the study, which is in 2018. And there's no blinding in the registry, so individuals would know which group they're in. The primary outcomes are the annualized presence of key bacteria pathogens listed here. And the secondary outcomes are the annual average of the lung functions and BMI-Z score. Our primary estimate are the annual treatment control contrasts, so odds ratio for the pathogen prevalence and mean differences for lung functions and BMI-Z score. And there would be 3 effects reported or estimated. First is the intention to treat, where we compare the groups by original assignment. And second is per protocol, where we censor the data when individuals deviate from their original assignment. And the third is a stricter PP effect, which is just a PP plus additional censoring at initiation of other HEMTs such as lumacaftor, ivacaftor, and tezacaftor, ivacaftor. And we would adjust for the following important relevant demographic information and clinical history in 2011. And missing baseline covariates would be handled using the missing indicator method. For the statistical analysis, we would run annual baseline adjusted regression models, which are just logistic regressions for odds ratios and linear regression for the mean differences. To evaluate treatment effect heterogeneity, we would conduct subgroup analysis by adding treatment by subgroup interaction terms into the regression models. And there would be 3 subgroups considered. First is CFTR mutation class. Second is age category. And for microbiological outcomes only, the baseline status. And the key baseline covariates that would be adjusted in the regression models are age category, sex, race, and outcomes on baseline value. We would only use complete cases for the analysis. The missing rate was about 3% for all outcomes except for the mycobacteria. Step 2, we emulate the target trial. So eligibility criteria, follow-up, outcomes, estimates, covariates analysis would remain the same. And to emulate randomization, we performed optimal multivariate matching, ensuring exact balance on the CFTR mutation class and 1:5 treated to control ratio. And we checked the balance of the covariates by calculating the standardized mean differences, or the SMDs, and we kept the SMDs to be 0.1 for all covariates. So after the matching, we have 613 treated individuals and 3,065 control individuals. And here's some mean outcome plots. So 2 things to notice here. First is in the baseline year in 2011, we can see that both groups have similar mean values. and that is an indicator of a good covariate balance. And second, we can already observe some ivacaftor-associated reduction in the prevalence of, for example, in here, Aspergillus, Staphylococcus aureus, and Pseudomonas aeruginosa. And on this page, we can see that the patterns we just observed is true for most of the microbiological outcomes, with Pseudomonas aeruginosa, Stenotrophomonas maltophilia, and Aspergillus showing the clearest signals. And on this slide, it's for the clinical outcome, in particular PPFEV1. And so we can observe same thing, good covariate balance at the baseline year, and an early divergence and persisting throughout the follow-up. And this is showing that the pattern we just observed is true for all the clinical outcomes. Okay, so for the previous few slides, it's just mean outcome plots. In the next few slides, we show the exciting part, the treatment effect. So just for the clarity of the presentation, we only provide the plot of the estimates coming from the third approach, which is the stricter PP effects. So on this page, it's the treatment effect and the 95% confidence interval for Aspergillus, S. maltophilia, and Burkholderia cepacia complex. The outcome is odds ratio, so if the line goes below 1, it means the ivacaftor is improving the outcome, and if the confidence interval do not cross 1, it means this effect is significant. So we can say the improvement is significant on Aspergillus and S. maltophilia since year 2012. But we cannot say that for Burkholderia cepacia. So this is showing all the effect on all the microbiological outcomes. There we can see that the effect is significant from 2012 for PA and S. maltophilia and Aspergillus. This is showing the effect on the clinical outcomes, and now the outcome is difference in means. So if the curve goes above 0, it means ivacaftor is improving the outcome, and if the confidence interval do not cross 0, it means the effect is significant. So we can see significant effects from 2012 for all clinical outcomes. And this is stratifying the effect by the mutation group. So now the lower the curve means the higher the benefit. So we can say that people with mutation group class 1 to 3 benefit more from ivacaftor on Aspergillus and PA, but we cannot say that for S. maltophilia. And this is showing the effect for all the microbiological outcomes. The key take-home message is people with mutation class 1 to 3 benefit more from ivacaftor on Aspergillus and PA only, and there's no clear distinction for the other outcomes. On this page, we showed the effect on the clinical outcomes stratified by mutation group, and we can see that people with mutation class 1 to 3 benefit more from ivacaftor on all the clinical outcomes. This is stratifying the effect by age group. So the lower the curve, the higher the benefit. So we can see that the youngest group actually benefit more, the most from ivacaftor on Aspergillus and PA, but cannot say that for S. maltophilia. And here is showing all the outcomes. So people age 6 to 18 benefit the most from ivacaftor on Aspergillus and PA only. There's no clear distinction for the other outcomes. Now is the effect on the clinical outcomes stratified by age group. So we have 2 bullet points here. So first, if you observe look at the BMI-Z score, we can see that people aged 6 to 18 benefit the most. But for the lung functions, people aged 19 to 30 benefit the most from ivacaftor. Okay, lastly, we for microbiological outcomes only, we stratified the effect on baseline microbiological status. So now, closely intertwined lines would mean that ivacaftor is equally effective in prevention and eradication. And for lines that are far apart, we cannot say that. So on this page, we can say that ivacaftor is approximately equally effective in prevention and eradication, the Staphylococcus aureus and MRSA, but we cannot say that for MAC. So this is showing all the microbiological outcomes. So the conclusion is that ivacaftor is comparably effective in prevention and eradication for common pathogens, but not for the rarer ones. And here, common and rare are defined on their observed sample size. And observed sample size is reflected in the width of the confidence intervals. So here we have 3 rarer ones, Burkholderia cepacia, Mycobacterium abscessus chelone group, and MAC. And the other ones are the more common ones. So summarizing our analysis results, we have consistent result across 3 approaches. Second is the ivacaftor's effect is significant across years for PA, asthmatophilia, aspergillus, BMI-Z score, and lung functions. And regarding the treatment effect heterogeneity, we observe larger benefit in people with CFTR mutation class 1 to 3, and 6 to 18 age group benefit more on microbiological outcomes, in particular aspergillus and PA and BMI-Z score, and 19 to 30 age group benefit more on lung functions. So for more common pathogens, ivacaftor is equally effective in prevention and eradication, but for the rare pathogens, the estimates are imprecise and inconclusive. There are a few limitations. First is an observational registry study, so residual confounding and measurement error cannot be fully excluded. So our causal claim rely on standard assumptions. Second is differential testing frequency, unmeasured adherence, and care access may bias results despite matching adjustment. So in conclusion, our results corroborate previous studies in causal association with lung functions, in causal association between ivacaftor use and improvement in lung functions and BMI. And our target trial emulation framework allowed us to expand on the prior studies demonstrating an association between ivacaftor use and microbiological outcomes. In particular, our results provided a greater confidence in claiming that these associations between ivacaftor use and improvements in PA and aspergillus are causal. And in addition, we identified a novel association between ivacaftor and reduction in prevalence of asthmatophilia that may be causal. And I think that's it. I would like to thank my dear mentor Ting Ye, my great coworker Jordan, and my fantastic collaborators Nico Hamlet, Chris Goss, Ranjani Somayaji, and Fang Han. And we would like to thank CFF, thank the patients, the care providers, and clinic coordinators at the CF centers. And thank you. I'd like to take questions.
Surely there's like a methods person that wants to ask a question. While you're coming to the mic, I'm curious. If I understand correctly, the individuals prescribed ivacaftor, they're for the first time in 2012, right? Can you, in this method, include anyone that is prescribed later? No. So they're all...
Yeah. There's only one time zero, and that is in 2012.
Okay, great.
Hi, not a methods person. I'm Jeff Atkinson from Washington University in St. Louis. I'm curious about the type of culture. So oropharyngeal swab versus a sputum culture would both show up as a culture, and whether the treatment groups had a differential in the amount of oropharyngeal swabs that were the result.
Yes, we did look at that, and I think there's I think the culture, there are 2 types of culture done. One is bacteria culture, the other is mycobacteria culture. So these 2 are separate. And I think for both of them, the maximum mean difference across groups is 1. So you at most differ by 1 culture done per year. So that in that regard, the I guess ascertainment bias resulted from differential testing frequency is minimal. Does that answer your question?
Not quite. So I I understand that. That makes total sense that we do less mycobacterial swabs than we do regular bacterial swabs in general, so that's true. The type of culture, you're more likely to collect, or you're unlikely to collect mycobacterium at all from an oropharyngeal swab. And young kids, a lot of times, that's all we can get is that type of culture. So I wasn't sure if your data included the type of culture that resulted in that, because I think the CF registry data includes that if it came from an oropharyngeal swab.
Yeah, if you're talking about the two types, the bacteria culture and mycobacteria culture, those two, we did look at that. Yes.
Okay, that's fine. Yeah.
Thanks for the urging, Liz. Okay. So this is only my second time being exposed to the treatment trial emulation approaches, and maybe you can say this in a few words, and maybe we need to talk later, but would you be able to compare like how this is different and why it's needed as opposed to a analysis where you did like adverse propensity weighting on the baseline status prior to going on ivacaftor?
Yeah, that is a good question. So I think, so target trial emulation is a framework. So, but IPW or matching, so all kinds of weighting, matching, and just regression, they're just methods or tools executed within this framework. Yes. So they're not just free-floating model choices. They're tools executed within this framework. So does that answer your question?
We have two from the app. Hold on a second. Have you considered antibiotic use as a confounder, and are the antibiotics more effective against common pathogens?
Yes, we did thought about that, but in the end, we didn't adjust for them.
Okay. And the second question, really interesting demonstration of this framework. Did the target trial or your emulation have any requirements for the number of cultures taken per year, and were those comparable across both groups per year?
There's no requirement on the number of cultures done. And just a little bit of defense, we didn't incorporate some of those things for two reasons. First is, for example, if you look at here, in the baseline year, the covariate balance is already very good, is already within the desired cap. And the second reason is the matching algorithm is usually is twitchy. So if you include more things, it gets bugged frequently. So those are the two main concerns. Yeah.
Great. And then I just have one other question. In this framework or this approach, can you talk about missing data? Do you absolutely have to have every covariate complete to include patients in this type of analysis framework? And I think you mentioned your methods, and did you consider multiple imputation?
Yes, we did try multiple imputation, and so we tried multiple imputation, but in the end we did not use that. Still, two reasons. First is after using imputation, the treatment effect estimates are still consistent with what we have now. It's very similar. And second is multiple imputation on large data set is also a little bit twitchy. So, yeah. If you're interested in more technical questions, we can talk about at my poster. Poster is 742. 742. Okay.
Great. Any other questions? All right. Well, thank you so much.
Thank you.
Okay. I welcome our final speaker, Ella Ed. She's a PhD student at the Research on Healthcare Performance Laboratory at Claude Bernard University in Lyon, France. And she'll be talking about medication adherence to cystic fibrosis transference conductance CFTR modulators, an analysis on the French CF population from 2012 to 2020.
Thank you. So I'm Elia Ed. I'm delighted to be here today to present our work on medication adherence to CFTR modulators, an analysis on the French cystic fibrosis population for patients who initiated the treatment between 2012 and 2020. This work was in collaboration with the French Cystic Fibrosis Network and the French Cystic Fibrosis Foundation, Vaincre la mucoviscidose. I have nothing to disclose. So CFTR modulators have significantly improved the clinical status of patients with cystic fibrosis. And to maintain these benefits, medication adherence plays a key role since it's essential for long-term effectiveness. And with electronic healthcare databases, we have the opportunity to track medication adherence and treatment patterns in real-world settings over time. So in France, ivacaftor was first available in 2012 for patients over 12 years, then in 2016 for those over 2 years, and in 2020 for those over 4 months. And for the association ivacaftor-lumacaftor, it was first available in 2015 for patients over 12 years, and then in 2019 for those over 2 years, and 2024 for those over 1 year. And the association ETI, it was first available in 2019 for severe cases over 6 years old in early access authorization, and started to be reimbursed in France for all patients over 12 years in July 2021. On the other hand, medication adherence is defined as having 3 main stages: the initiation, which is taking the first dose, then the implementation, which is how well patient is taking the treatment as prescribed, and then the persistence, which is how long patient continues to take the treatment over time. Understanding these patterns is essential to maximize medication adherence and treatment effectiveness in real-world settings. So the aim of our study is to evaluate the long-term medication adherence to CFTR modulators in its both aspects, implementation and persistence, and to explore associated factors. For this, we linked 2 databases. The first data source was the French Cystic Fibrosis Registry database, created in 1992 for epidemiological follow-up. It covers all 47 French cystic fibrosis centers and supported by the French Cystic Fibrosis Foundation, Vaincre la mucoviscidose. The data is collected, coded, entered securely with a quality control, statistical analysis, and a yearly published report. The second data source is the French National Health Data System, SNDS, created in 2016 for public health research, follow-up, and policy. And it covers all French population for up to 20 years of historical data and supported by the French National Health Insurance, LACNAM. Its main components are the health insurance claims, the hospital discharge data, and the causes of death. This database provides a longitudinal follow-up with detailed drug and care data and a secure authorized access and scientific and ethical review by the French Ethics Committee, which is responsible of the ethical reviewing of all research projects, health research projects, especially those involving health data, and LACNIL, which is the National Commission of Informatics and Liberty, responsible of the protection of personal data in France. For the linkage, we first do the initial coupling based on sex and month and year of birth, followed by a weighted scoring based on several variables, such as the region of residence, follow-up centers, and the index CFTR modulator. Then our patients were included for the study. For the study population, we included patients with cystic fibrosis aged 60 and more, with at least 6 months of treatment, and who initiated CFTR modulators for ivacaftor between 2012 and 2020, for ivacaftor-lumacaftor between 2015 and 2020. Unfortunately, for patients who initiated ETI, we couldn't include these patients since we had the data for the analysis until 2022. And as I said before, ETI was started to be reimbursed in France in July 2021. So due to lack of sufficient follow-up period, we couldn't include them, but it's one of our main objectives in a current study we are conducting. Then we calculated the implementation and the persistence for over the first and the second year of follow-up period. For the medication adherence methods choices, we used the CMA-7 measure for the implementation, which is the continuous multiple interval measure of medication availability version 7, which is equal to the number of days covered over the fixed observation window. For the calculation, we have several parameters. For the supply coverage duration, we consider that a 28-tablet pack covers 28 days. For the hospitalizations, we considered that the hospitalized days are covered if the treatment was dispensed before admission and after discharge. And we considered that ivacaftor and ivacaftor-lumacaftor were not interchangeable. Then we calculated the mean CMA7 and the percentage of adherent patients at the first and the second year follow-up periods. Considering that optimal implementation, we have an optimal implementation for a CMA7 value equal or above 0.8, which is presented in the literature. For the persistence calculation, we consider that there is a treatment discontinuation if we have an allowable gap above 84 consecutive days without coverage, which is equivalent to 3 times 28 days. And then we calculated the percentage of persistence patients. For the variables, we have the age, the sex, the complementary health solidarity, which is the government health insurance program in France that provides health coverage for patients or residents, French residents with low socioeconomic income. For the French deprivation index, it's an index in France which reflects the deprivation level in a geographical area. We also have the nutritional status, the CF centers, the index CFTR modulator, the number of co-therapies, the best ppf EV1%, the CF-related treated diabetes, the bronchial colonization with Pseudomonas, and the number of pulmonary exacerbations. In our study, we included 1362 patients who initiated the treatment between 2012 and 2020. With a mean age of 19 years, 53% of men, and the majority with the bitherapy. For the implementation, the mean CMA7 was 0.88 at the first year, with an almost stable value at the second year, and a decrease of 4% of the percentage of adherent patients between the 2 years. However, for the persistence, we have a decrease over 20% between the first and the second year. For the associated factors, we found that being younger than 18 years, having a higher socioeconomic status, a higher number of co-therapies, and a more advanced stage of the disease were associated with having an optimal implementation to CFTR modulator at 2-year follow-up period. For the persistence, we found that being younger than 18 years, being man, and having ivacaftor at index therapy were associated with having an optimal persistence to CFTR modulator at 2-year follow-up periods. So, in our study, we found that overall we have an optimal implementation for the first and the second year with a decrease in the persistence between the 2 years. This can suggest that treatment challenges to CFTR modulators are more related to treatment disengagement rather than dosage adherence problems. For the associated factors, being younger than 18 years was associated with implementation, and that can suggest that this can be due to parental supervision. So a particular attention is needed when moving into adulthood. A higher socioeconomic status was also an associated factor. This may be due to health literacy, a higher resources access, and that patients are more involved in their treatment. Having a higher number of co-therapies and a more advanced stage of the disease can help also in the frequent monitoring and can be like a motivator for the patients to take their treatment. For the persistence, being male was associated with an optimal persistence, and there is a study that suggests that patients with cystic fibrosis were more positive into long-term outlook into their treatment compared to women. Having ivacaftor as index therapy was also maybe due to clinical benefits of ivacaftor. So in our study, we used real-world data, which is a practical and cost-effective approach, and we linked two complementary national databases, which can make our results more generalizable. However, we have faced several challenges. Since in the SNDS, we have the dispensing records rather than the actual intake. And also, despite the national level coverage, we had like a small sample size. We couldn't also include the ETI patients. So finally, with the game-changing impact of CFTR modulators and the new profile of cystic fibrosis, assessing medication adherence became important. And with the growing availability of real-world databases, we have the opportunity to assess this medication adherence to help us in the clinical practices and policy decisions. Thank you so much for your time, and I would love to meet you all at the poster 7:30 to hear your thoughts and to discuss more about our work. I want to thank also the French Cystic Fibrosis Network, the French Cystic Fibrosis Foundation, and the French Cystic Fibrosis Center in Lyon for their help. Thank you.
Okay. Do we have any questions from the audience? Great, thanks.
Thanks for that great presentation and an interesting way to link administrative data with registry data. I'm curious, were you able to look at whether persistence or implementation is associated with other clinical outcomes later on, like where people who had the population that had lower rates of persistence have any adverse health outcomes?
I don't know if I understand well your question. So how can we, from the variables that we have, associate these to the implementation and the persistence? That's what.
So I think you look for risk factors for those factors that might be associated with individuals that might have lower rates of persistence. But I'm asking sort of the flip side, which is if you have lower persistence, is that associated with worse outcomes?
Yeah. It was like a method of choice because we are searching in the medication adherence subject research area. We search for we search more about the optimal implementation and the optimal persistence rather than the non-adherence. So we try to standardize the method, to search more about the adherence rather than the non-adherence.
I have a question. This is really fascinating, and I'm not very familiar with the data structure in France. How many people, did you get the proportion of people that you were expecting to find, based on the French CF population? Were you able to find them in this administrative data set? Like, how well did your linkage perform?
So how did we have before the linkage?
In the US, this is always hard because our data are different.
Yes, it's different.
But in the case of France, you have your national health system and your administered claims. Was it 100% match between the patients in the clinic?
No, because for the French Cystic Fibrosis Registry, the data is collected annually, which is not the case for the SNDS. For the SNDS, we have the dispensing records and several other records that we have that are collected every time patient is the treatment is delivered or the patient is having the diagnostic. So it's a little bit different, yes. So there is for the time it's different. For the registry, it's per year. For the SNDS, it's per dispensing date.
Do you have people in your French registry that you didn't find in the administrative data, or vice versa?
Yeah, there is. I don't remember the percentage, but we have a small percentage that's not matching.
Oh, great.
I have a question. It's more of I'm not familiar with the sort of what is it called? CMA7
Yeah.
Is that are you able to take into account something like probably more relevant for Trikafta, but people who are reducing a dose, like they're not taking a full dose, is that methodology able to take into account those types of things?
So for the medication adherence measures, we have plenty of methods to
Okay.
calculate medication adherence measure. And it's one of our projects to standardize these methods. Until now, there is no standardized method to calculate for the CFTR modulators. But what we can do is to, with the choices of the parameters, try to adjust for the CFTR modulators. Like, for example, for the supply coverage duration, in France, we have like a package of 28 pills pack for the ivacaftor and the association ivacaftor-lumacaftor. So with the choice of supply coverage duration, we are trying to adjust for the CFTR modulators. So the choice of parameters is helping in the adjustment for the treatment.
Okay, thank you.
Any other questions? Okay. Well, thank you so much for the
Thank
great
you.
presentation. Well, Stephanie, we are finishing ahead of schedule and under
are.
budget, apparently. So thank you all for coming. I did want to just highlight that, it is important for international registries to collaborate together, despite our baseball differences, for those of you who follow. There is an evaluation form on the app. If you'd love to provide feedback on this session, it'd be great. There's so much exciting registry-based research happening across the globe, and we're really happy to have this forum to highlight that and have you all here. And so would be great to plan for future sessions. But welcome to Seattle. And I'm sorry we're not hosting the World Series on Friday.
Go Jays, go.
No.